What do we do from a clinical standpoint today? It's not just the amount of bone that you have on the labial plate, not just the thickness, but we also know from what you've seen and new studies that are coming up that the influence of the soft tissue thickness is not just critical for color changes. Thickness of soft tissue in that critical zone where the implant and the restorative abutment and the crown come out of the tissue, the thickness of the tissue will also affect the stability of the crestal bone in that area. And this is becoming more and more evident and something we really have to pay attention to. So very often when we're dealing with soft tissue, you can't necessarily change a flat biotype to a scallop biotype, but we can change a thin tissue to a thick tissue through grafting. And when we have it in critical areas of the aesthetic zone, we certainly have to do that. 5 critical diagnostic criteria that we use in our practice in implant dentistry. We spend a great deal of time on space analysis and proportion analysis through wax-ups, through measurements, to make sure that we'll be able to work in a zone that has optimal spacing for the best tooth form placed in there. Gingival harmony. One of the first things we look at is the area I'm placing my implant in harmony with the adjacent natural dentition. Labial plate. Is it present? Is it deficient? Do I need to reconstruct it? And the interproximal height of bone. Very, very critical. Sometimes, very often, it's not enough to really look at a two-dimensional X-ray or PA to determine that. And the critical wild card, if you will, biotype. Thin versus thick actually is much more important in implant dentistry to make that diagnosis than whether it's flat or scallop. Thin versus thick is the critical component that will affect our treatment plan and will affect our enhancement of that particular interface. When we have thin tissue, we may graft it, we'll use ceramic abutments, we'll change the subgingival contour of the abutment, as you'll see, most often reducing contour, creating a concave or flat emergence profile. What do we do clinically when patients present? We very often, in critical cases, high smile line, we'll anesthetize them and do bone sounding. Where is that labial plate of bone? We can't trust where the soft tissue is. We want to know where the labial plate of bone is. Where's the interproximal bone? And of course, today, more and more what we do is we measure the thickness of the soft tissue 2 to 3 millimeters apical to the gingival margin prior to extraction so that we understand what thickness of tissue that we're dealing with. Very critical aspects of our diagnostic and treatment planning protocols. So when we do that, we're able to then take even cases in thin tissue, thin biotypes, and create durable restorations. Let's look at extraction sites and how we plan out those interfaces. Is a fracture very deep on the palatal aspects? Labial plate is very thin in these types of cases, and actually, according to studies coming out of Bern and Geneva, 90% of labial plates are a millimeter or no greater than a millimeter. So we're usually working with very thin labial plates, and we need protocols to protect that interface, especially at that crestal 2 to 3 millimeter zone, where the bundle bone is most prevalent. How do we do that clinically, especially in type 1 site, which is what we diagnosed this case? Type 1 site means that we have good labial plate of bone. We do bone sounding to check that. We also know through bone sounding that we have good interproximal height of bone. And that then makes it a type 1 site, and we want to preserve this site. Happens to be a scalloped area. The tissue was a little bit thick in this case, so we decided to utilize a flapless approach and a minimally invasive approach in this case as well. And what you see here is that after extraction, we go back and make sure that our initial diagnosis is actually accurate. So we'll go and bone sound again to the interproximal, look at the labial plate, check that there's no perforation of the osteotomy. And only then do we start to check and verify that what we've done virtually through our digital diagnosis is the same as what we find clinically. We also want to go in and place our implant in such a way that we actually engage the mesial and distal walls of the socket and the palatal that stay away from the labial plate of bone. We usually want to create and choose a diameter of an implant that allows us to engage mesial, distal, and palatal so we can get good primary stability. That's where the macro geometry of the implant design, we look for an implant that has a good thread design that can give us primary stability well into the range of 60 to 70 newtons resistance. We also want to have a diameter that allows us to maintain a gap between the labial plate and the implant of between 1 to 1.5, at the maximum 2 millimeters. And if you notice from a design standpoint, in addition, when we look at implant design, if you use an implant with platform switching capabilities, as in this figure, your distance from the labial plate is not the labial of the implant to the bone. Your effective distance as it relates to the biologic width is actually from where the abutment, the future abutment, restorative abutment, will come out of the implant to the labial plate. That's the effective distance. And if you can really keep that at 1.5, your influence on that labial bone relative to biologic width remodeling will be minimized. And that's why we look at implant design incorporated in our decision making. Clinically, how does that look like? When we look at some of the clinical studies, Araujo, Botticelli, Nevins, Cardaropoli, all really follow through with a lot of what we're saying relative to the extraction site. That research base to create some of our decision-making processes. So, as you can see, we engage interproximally, mesial, and distal and palatal, that we stay away from that labial plate bone. And in this particular case, you can see that, yes, we've mimicked what we've seen in our virtual planning. We will then graft that labial plate from inside the socket in the combination. This is autogenous bone and PRGF. And then we will place our implant, and immediately in this case, because we have a very high degree of primary stability, more than 70 Newton centimeters, we're able to temporize a very critical component that we do to protect that interface. When we are doing immediate temporization at the time of extraction and implant placement, we don't use standard dental cement. We actually use an antibiotic ointment, a very retentive temporary, and this way we don't have a risk of getting any type of cement into that interface between the implant and the abutment. We also under-contour the abutment, a very critical aspect of what we do. Subgingivally, we under-contour the abutment. And very often, and even in the final restorative abutment, we will do that as well, depending on the tissue. In this case, this is not a thin tissue, so we only under-contour slightly. On the left part of your screen, you're looking at 1 week healing and 8 weeks of healing on the right part of the screen. Notice that we've maintained the high degree of scallop around that temporary, but also look at the soft tissue. In a way, we're actually, because we're under-contoured, we're actually about a millimeter or more coronal on the soft tissue margin than on the adjacent tooth. And that has to do with subgingival contour. So part of what we're focusing on today when we talk about implant design and abutment design, that aspect of it is what is reflected in these slides. subgingival contour, abutment design, not only material, is very critical when we're really looking, manipulating surgeon's profile and the display of the soft tissue around particular implant supported restoration. And you notice because it's under contour, it's more coronal. We don't cut this away. We actually use contour when we get to the final restoration and check our biologic health around the final abutment. Because the tissue is more than 2 millimeters thick in this area, we're using a standard abutment, metal abutment. And at this point in time, we can add contour to literally push the soft tissue more apical. And you'll see a little blanching in this area as we've added contour to the final crown because it's more contoured than the temporary. It will blanch a little bit while we're waiting on it, but certainly we've been able to create a situation that in as little as 10 weeks has been able to deliver a final restoration in a type 1 site in tissue. That color is very critical, especially because of the ethnic nature of this tissue pigmentation. What happens when we don't have a labial plate? We're working in a type 2 site, as you see here. The aspect of this failure is this tooth was taken out, but we have good interproximal bone, as you see both on the x-ray and clinically. When we have good interproximal bone, this is classified as a type 2 defect, and we're going to do standard augmentation techniques. In this case, an autogenous block is placed from the symphysis, and you'll see how we handle that. But the interfaces of our augmentation procedures also become critical. Here we are at 4 months. We like to go back in autogenous augmented areas of block areas at about 4 months. This patient went home with an Essex appliance as a temporary, and at 4 months, we're able to go in, and I want to share with you the implant placement and really look at the situation where we can go back in after you've augmented the site. And even though we always try to over-correct areas at every aspect of our augmentation, because our goal is to take it, in this case, a type 2 site, make it into a type 1 site. Even when we've augmented the area and over-augmented it and over-corrected because we take into account a certain level of remodeling of the bone, after implant placement, that labial plate is still only a millimeter thick. So what do we do to protect it? How do we protect that very, very critical interface? We'll go in, we'll use a xenograft, in this case, and we'll pack it in. We want to use that to create a scaffold in this area. We'll mix that also with PRGF. We'll use a resorbable membrane, and on top of that, we'll also use a connective tissue graft in a layered technique that allows us not only to thicken the labial plate, but also to thicken the soft tissue. Again, always with the mindset, we're raising a flap, let's overcorrect the area to really make sure that we have the kind of environment that's as close to a type 1 site as possible so that the restorative dentist and the ceramist can do the best work they can. And you'll see that with the final, once the implant is also integrated, we fabricate a temporary for it and eventually a ceramic abutment and the final restoration. And you can see how we thicken that tissue, and in fact, the tissue color on the implants actually probably more aesthetic than even the adjacent natural tooth. So taking a very, very resorbed labial plate, reconstructing it, creating an interface around that implant abutment connection becomes very critical. What are some of the trends as we go forward to combine several of the aspects that we are looking at? Fractured tooth, because of a large post, we're going to extract it. A critical component here from looking at the interfaces that we want to really verify is, did this defect around that post and the defect that you see on the mesial of the left central incisor, did it compromise the labial plate of bone? One of the best ways we can really affirm that is looking at the digital technology, evaluating that. Where is that labial plate? And whether we can involve and create some CAD/CAM environment for it. And through this, we can see that the labial plate was actually present. It wasn't compromised with that fractured post. And we're able to utilize a minimally invasive procedure. How else can we do it? Not only today do we use our virtual treatment plan to know how to place our implant and to create surgical stents to place our implants, we can actually then transfer that information to the restorative dentist or the laboratory technician and allow them to actually place an analog on a model and create a situation where they can virtually take that information that we created virtually on the computer and actually transfer it to a model and fabricate a final abutment as well as a temporary, so that we can facilitate a very efficient placement of the implant according to our treatment plan, very, very precise in orientation, and at the same time have available to us right at the chair a abutment that's designed for the tissue type that we have, and we can then put in the final abutment at the time of implant placement so that that connection becomes the most durable without having to put on and take off many different components through what is a normal standard cycle. Transfer copings, temporary abutments. So in this case, what you're seeing is actually the final abutment fabricated. A temporary is fabricated as well, and then we're able to have that ready at the time of implant placement. And this can also be done on a stereolithic model. You can see an analog is placed right on the stereolithic model, utilizing the surgical stents. A final ceramic abutment in this particular case is chosen, and a temporary is fabricated. So the day that we extract that fractured tooth, we can actually place our implant and have a final abutment to go directly in there one time, as we call it, one abutment, one time, and the tissue integrity can be started straight from the day that we place our abutment. This happens to be a Xive implant, the Freedent Xive implant, and as you'll see, we're able to then temporize it with a temporary that was already fabricated, slightly out of occlusion. There's no occlusion both in centric or eccentric movements. How does that look clinically? When this case was done, you can see from our virtual treatment plan, we took our surgical stents, fabricated our abutments, chose the abutment, chose and fabricated a temporary restoration, had all the information that we required ahead of time so that when the patient came in, we had already chosen the implant size and diameter, length and diameter. We had our final abutment, as you can see here, and the temporary. The tooth is extracted. Surgical stent is utilized very, very precisely according to our virtual treatment plan. Place our implant. This is a Xi 4.5 millimeter implant. And place our final ceramic abutment, the zirconium abutment, and the temporary. The only thing we have to do now is make sure that temporary is out of occlusion. Literally, from beginning to end, this type of planned case very often takes less than 30 minutes for a single unit. So when we look at this case, here's the temporary on the left part of the screen at about 8 weeks. Notice that the ridge and the soft tissue are intact. This is due to the fact that we augmented and grafted the inside of the socket, that gap, both with bone and soft tissue, creating a stable environment. At the time of transferring this relationship, we don't want to take out the abutment, so the laboratory created a transfer coping for us. This way you don't have to pack cord. We don't have to disturb the attachment of apparatus and the tissue and apparatus around the implants. And we just take this transfer, zirconium transfer, and put it onto the abutment. And now we can transfer this to the laboratory where the ceramist will just cut off that retentive groove in the occlusal area and then build up the porcelain directly onto that abutment. And that would be our real display of that concept of one abutment, one time, don't disturb the tissue. Whenever we can, in the type 1 site, place the final abutment at the time of implant placement. Transferring it to the laboratory, very critical aspects now that the laboratory takes over. What you're seeing is that we want to leave the implant either with flat or concave emergence profile. This becomes very, very a critical component. So when you talk about abutment design, you want abutments that actually create a concavity there. What does this do for us? It doesn't stress the labial tissue. And another component is it creates and allows us to have more thickness of tissue. Because we're not bulking out the tissue, we don't have a convex emergence profile, we're actually creating more room to thicken that tissue and end up with that goal of 2 millimeters of thickness. So as we can see, the left is your temporary, and the final crown, the final restoration on the right part of the screen. The left would be immediately after extraction and temporary restoration, and again the right, the final restoration. And what you've seen in many ways in this type 1 site is that our goal was to preserve that site. And in fact, if we really look at it, we've kept the pillow where it is, we've kept the temporary where it is, and you can see that we've been able to take that area and put in an implant and interface that certainly will allow us to maintain that environment.